everyone. I missed seeing all of you at lunch.
Thank you.
I saw your hand up, Dr. Stewart. Okay, we will go ahead and begin with our agenda item number 14, the Western Regional Examination Board Report.
President Pacheco, this is the moderator. If I can for just a moment, I'm doing a quick visual check to make sure we have everybody connected with us.
Thank you.
Our number dropped by 1, and I just want to make sure it wasn't a board member. Board Member Burton, it looks like your audio is not currently connected. Can we do a microphone check? I'm not sure if she disconnected it during lunch and has not come back yet, or if it's lost its connection.
President Pacheco, this is Sarah Wallace. I'm wondering if we would like to ask the secretary to maybe take a roll call just to do an audio check to make sure we have everyone back from lunch.
That's a great idea.
Staff are working with Board Member Burton to have the audio reconnected.
Okay. Board Secretary, please take the roll.
Okay, this is Dr. Felsenfeld, Board Secretary. I will take the roll. Member Burton? I'm assuming she is not connected based on what the moderator was just saying. Felsenfeld is here. Lai?
Here.
Present. Laren? Lorene? Lorene present. Mackenzie?
Mackenzie present.
Mackenzie present. Medina?
Medina present.
Medina present. Mendoza?
Mendoza here.
Mendoza present. Molina?
Molina present.
Molina present. Montel?
Montel present.
Montel present. Morrow?
Morrow present.
Morrow present. Olagi?
Olagi present.
Olagi present. Pacheco?
Present.
Well, Pacheco present. Stewart?
Stewart present.
Stewart present. You
present.
You present. Madam President, we do have a quorum. Ms. Burton is still not, looks like she's on as yet.
Okay. Ms. Fisher, do we want to move ahead with the agenda or wait for Board Member Burton?
I think let's move on.
Good answer.
Okay. All right. We'll move on to agenda item 14A, Western Regional Examination Board Report. I will ask Dr. Mark Christensen, Assistant Director of Dental Examinations for the REB, to present this agenda item.
And excuse me, it looks like Ms. Burton may be reconnected. Can we do a mic check? Hello.
We can hear you. Thank you.
Thank you.
And President Pacheco, this is the moderator. Just to let you know, Dr. Mark Christensen was with us earlier. We did do a mic check this morning. Looks like he has dropped off the meeting, however, at this point in time.
Okay.
We do have our two individuals present for 14B, however.
Okay. With
And I'm going to
permission.
jump in too. Dr. Felsenfeld, this is Karen Fisher. If you would mark Ms. Burton present. Thank you.
I will do that, ma'am. Thank you.
And with permission, I will go ahead and move on to the agenda item 14B, American Board of Dental Examiners Report. I will ask Dr. William Pappas, President of the ADEX, and Dr. Guy Champagne, Vice President of the ADEX, to present this agenda item, and then we will circle back to 14A. Thank you.
Thank you, President Pacheco, board members and board staff. Dr. Champagne and I appreciate the opportunity to present on behalf of ADEX. We will present findings from the exam cycle for the class of 2020. You'll hear the comparison of our new candidates for licensure, how our candidates for licensure performed on the simulated human tooth, the Confidant, and performance treating patients. Dr. Champagne will show you some of the treatment outcomes, and he will draw some inferences from the data collected. I will share statistics for the class of 2020. Dr. Champagne?
Sure. Now, somebody, oh, good, you have the PowerPoint. Thank you for the opportunity to present. As Dr. Pappas said, we're going to go over the analysis of the class of 2020, which ended December 31st of last year. It really gave us a special opportunity because of course, the unique challenges that everyone met in the country that COVID presented. Next slide, please. So one of the things that it allowed us to look at is, are psychomotor exams even necessary? Did they add to the information in a licensure process? Next slide. Now, one of the things that, of course, is going to be unique and new this year is how did our Confidant tooth perform? It is not a Typodont tooth. It's not even manufactured in the same way that any other tooth really in the world is manufactured. It was developed to simulate the disease process and the tissues in a human tooth. The goal is, and I'm going to be brief on this because we've talked about it before, but there are, in case any new board members or somebody who had missed, our goal was ACLS, which is really the gold standard in a simulation because of the increased amount of variability that you can add that no one patient can present with, but at very realistic outcomes. Next slide. So one of the things that we were looking at in developing it, we looked at all the existing teeth, but with the Confidant tooth, we wanted to simulate the disease, simulate the biological progress of the disease, as well as the response of enamel and dentin to caries. We wanted, most importantly, to reproduce the variability. No two patients are the same, no two caries progression is the same, no two pathways are identical. There's really a spectrum of how dentin is affected, from decalcified to frank caries to sclerotic dentin. And the different tissues, both enamel and dentin, we wanted it to perform as it did in a patient. Next slide. Now, we're only talking about one component of the ADEX exam, so I do want to emphasize that. And we do a complete psychometric analysis on all the sections. It really is 4 sections. The top section you see there, periodontal scaling, is optional. It has not made the occupational analysis cut score for 18 years. I think it's pretty well settled. Almost all testing agencies, if not all, that is an optional section. The reason it is historically maintained is because of the declining number of dental boards which require it in their statutes or rules. But we also have endodontics, prosthodontics, which is required in the ADEX exam because it, in fact, is the highest, other than diagnosis, treatment planning, and medical considerations, it's the highest skill set in the occupational analysis, and of course, the restorative. Our OSCE exam, which has been continuously maintained since 1969, was significantly overhauled about 5 years ago. is where we test everything on our occupational analysis that can't be tested in a psychomotor exam or should not be tested in a psychomotor exam. For example, applied anatomy, applied pharmacology, postoperative complications, periodontal diagnosis, etc. Next slide, please. So I'm going to quickly go over what the confidant tooth is and how it is different. Next slide. This next slide really just shows you there is a sharp demarcation between dentin and enamel. It looks the same as a tooth. It feels the same. So the restorative faculty and testers that we use to prepare the tooth and develop the tooth, in fact, their comments were if they closed their eyes, they couldn't tell the difference between a human tooth and this tooth. Next slide. This just shows that we do wanted to reproduce caries. I can't show this in the picture, but the caries is actually suspending that explorer. It is not being held by anybody. It does have a tug back if you try to remove it. Next slide. And as you'll see in this slide, if you look along the DEJ, the caries promulgates along the DEJ just as it does in that we see in human teeth. Next slide. And the caries can extend in any direction, and you could have remaining caries that is either stained or unstained, as in adolescent patients, because we wanted to have the full panoply of decision-making that a candidate might have to make. Next slide. But it is not a color identification test, so as I said, not all caries are stained. And not all stained material is caries. That's sclerotic dentin. It can't be penetrated by the explorer, and that is another diagnosis, tactile diagnosis the candidate has to make in developing their treatment plan. Next slide. This is about the size of the finished prep. Next slide. So it's larger than what the average candidate would choose for an examination if they were choosing a patient, but it allows us to evaluate their judgment, evaluate their alterations in treatment plan, and it can be finished in exactly the same way with the same armamentarium. This is as hard as enamel. You have to bond for the composite to adhere, and you can use whatever finishing techniques you would normally use. Next slide. What we wanted to do is develop something where we could evaluate every ADEX criteria. Next slide. And so what we found was the same errors. So this is, we saw overextension. This is, again, this is as hard as enamel. It is not accidental. This is just a clinical error here. Next slide. We had unrecognized exposures and inadvertent exposures. Next slide. Here's another exposure. Next slide. Again, exposures, chasing decay, not knowing when the decay ended, when they got to intact dentin. These were not justified exposures. They were not carious exposures. Next slide. Adjacent tooth damage. Next slide. And of course, remaining caries. You can see caries there in the DEJ. Next slide. You can see it in both the incisal and as well as a rather unusual outline form here. But this is stained caries. Next slide. This caries is unstained. It's penetrable under light pressure with an explorer and exhibits tug back, as is in the next slide, please. So it does not have to have stain. We wanted this to be a clinical diagnosis in the same way that a dentist has to evaluate the tissue that they encounter in a patient. Next slide. Again, more caries remaining. Next slide. Now, what opportunity it afforded this year, which was unique, is 40% of the candidates taking the ADEX exam took it after graduation. That is an unusual situation for ADEX. Most of our candidates are finished well before graduation. So I'm going to show you some performance that occurred from June 2020 through December of 2020. Every single candidate that I'm going to show you graduated dental school, is a dentist, successfully completed all the CODA required competencies, passed the national boards and passed the OSCE. They demonstrated appropriate judgment and knowledge of clinical principles. Yet, next slide, this was a preparation that a dentist submitted for grading. They thought they had finished and they were ready to have it graded. There were no modifications on this preparation. That axial wall is almost at the central pit. That material you see in the reddish material is actually pulp that they went into. And for whatever reason, that candidate didn't recognize it. Next slide. Another preparation done by a dentist, not a dental student. Somebody had passed everything from a judgment point of view, submitted that to be graded. Next slide. This is another preparation. I mean, it's almost, it's difficult to understand that a dentist felt that this was appropriate. I want to have this preparation graded. It's completed. It's ready to fill. Did not recognize the problems. There were no time constraints. There was nothing that stopped this candidate from doing something. So to me, this is significant evidence that a psychomotor exam where you have to perform is something different than your judgment and understanding of principles. Can you actually do it? Next slide. This is a restoration placed by a dentist, not a dental student. Next slide. Another one. This was a restoration. They can remove it, they can replace it, they can recontour it, they can finish it, they can do anything they want. They chose to have this graded. Next slide. Another restoration by a dentist. Next slide. Again, a restoration. Someone thought this was appropriate care for the patient, in this case, a competent tooth, but thought it was appropriate and submitted it for being graded. They decided, I don't need to remove it. I don't need to recontour it. This is the best I can do. It fulfills principles of dentistry. Next slide. Another one. Next slide. Next slide. And next slide. Next slide. So when I show you these restorations, when I show the preparations, to me, it makes clear the answer. Does the psychomotor exam add anything to our knowledge? Had these dentists not taken the exam, they would never have been identified. They passed all the cognitive exams. They graduated dental school. They had done everything they were supposed to do except independent, on-demand, acceptable performance. If they thought this was acceptable, which they did because they turned it in for grading, they could have removed it, they could have redone it, they could have recontoured, any of those things. It's almost unexplainable. But if they think that's adequate, they would do that for the patients. No one would have stopped them. Next slide. Another one. Next slide. Finally, so what did we see over this cohort of, in especially the competent, because that's what the whole goal was, ADEX wanted to develop a non-patient alternative because there are ethical issues when patient care is part of what we're evaluating. If we can eliminate the need for that and adequately test their psychomotor abilities, that's a step, that's an advancement in testing. And what we found was the same critical errors that we see in our patient-based series for years. So there was caries remaining, stained and unstained. And it was interesting, we'd see comments by test takers, well, something's wrong with the tooth. The decay wasn't stained. They had never seen unstained caries. In fact, one of the deans who came down to check all the failures commented that it identified a deficiency in their program because they didn't see adolescents. We saw open contact, debonded restorations, irregular contacts. You saw the restorations and some of the things that we see, over preparation, excess, doing the wrong tooth, modifications. In fact, every critical error we see in patients. Next slide. but it gave us actually an advantage. The advantage it gives is the examination is actually fair because it's uniform. Every candidate has the same difficulty of challenge. It wasn't based on your ability to find a patient that would offer the minimal possible care. They weren't self-identifying their test material. You know, a patient shows up in the office, you need to treat what you see. The lesion has to be treated without consultation, so it is done independently, and we can test every knowledge, skill, and judgment that the subject matter experts determine must be tested. Next slide. All the lesions required modifications, so we could evaluate their judgment. Next slide. And of course, there's no patient recruitment risk or payments required. In fact, the errors were the same. Next slide. But we were able to evaluate judgment, and we presented a little bit of this to you before, but basically, if all of your modifications were granted, your judgment was appropriate, what you wanted to do was appropriate, that was the highest pass rate. And as the number of modifications are declined, the failure rate goes up. But because you had all modifications granted, did not ensure you would pass. It did demonstrate a total independence. So people had appropriate modifications. This is what I want to do, but they could not accomplish it. So we were able to test the value of both judgment and hand skills. And of course, the highest pass rate is if you have both that in an adequate clinical performance. Next slide. So with that, I'm going to turn this over to Dr. Pappas because he's going to give you the actual statistics comparing patient-based and non-patient-based candidates.
Thank you, Dr. Champagne. These next several slides will have some pass rates, and then we're also going to talk about the top 3 failures. Those aren't exclusive of other possible failures. They're just the top 3 failures. For the class of 2020, since much of the class had taken the exam when the lockdown began, we had nearly 2,700 candidates perform the anterior restorative on a patient and just over 1,100 on the confidant. As you can see, the pass rates were nearly identical. Oh, I forgot to say next slide. There you go. Now you can see that the pass rates were nearly identical. Next slide, please. For the most common errors leading to failure, 2 of the 3 errors were shared between the patient and the confidant. These were remaining caries and unrecognized exposure. Remaining caries was the #1 reason for failure for both. Next slide, please. And next slide again. For the anterior restoration, all 3 of the top 3 reasons for failure were the same in slightly different order. Next slide, please. And we'll move on to the posterior. Next slide, please. Again, for the comparison of patient and confidant, the first attempt pass rate is virtually the same. Next slide, please. For the posterior, as in the anterior preparation, remaining caries was the #1 error leading to failure on both patient and confidant. Adjacent tooth damage was also common to both. Next slide, please. For the posterior restoration, 2 of the top 3 errors were shared between the candidates treating patients and those performing on the confidant. Next slide, please. As you saw, the same errors leading to failure were common to both patient-based and confidant. Caries identification is as critical to the confidant as in the patient. Due to the ability to control the amount of caries on the confidant may provide a better examination, and as Dr. Champagne had said, likely does. The first attempt pass rates were nearly identical. Differences in the rendering of treatment between the patient and the confidant, such as the use of anesthetic, don't make a licensure decision. So those factors that are often brought up as a reason to maintain treatment on a patient, it's not based in fact, because someone doesn't fail this examination due to inadequate anesthesia. I've never seen that, and I've never talked to anyone else that's encountered that. They're able to get anesthesia, and so that's not a deciding factor. Next slide, please. For 2022, we will be adding multiple lesions on multiple teeth. Approximating surfaces will be confidant teeth instead of ordinary typodont teeth. Anatomical refinements such as posteriors will be made. Candidates will have to diagnose the lesions which they will treat. Practice teeth will be made available, which are not examination teeth. Next slide, please. As you may be aware, the dental scaling exercise is optional for the ADEX examination, as Dr. Champagne mentioned. The first bullet point notes scaling by a dentist has not made the cut score for our national occupational analysis for 18 years. Periodontics is included in our DSC OSCE, a computer-based examination offered at Prometric sites. Next slide, please. And thank you, President Pacheco.
Thank you, doctors, for the presentation. Are there any comments or questions from the board members? Please use the raised hand feature. Dr. Lai, you have a question, comment?
I think Dr. Mantell was it before me.
Dr. Montel?
Hi, yes. I have a question regarding the practice teeth that you mentioned that would be made available. Just to clarify, are you talking about practice teeth that they can practice before the exam, or are we talking about them allowing students to use this type of tooth when they're actually in dental school before they see patients and they can actually practice with this kind of caries, with the caries available for them to practice on?
I think that would be up to the school, but the practice teeth that we talked about providing are for them to practice for the exam. Our contention is that as they treat patients, that should be really enough practice to take this exam and pass it. But there's been a call for practice teeth. Dr. Champagne, do you want to add to that?
Yeah, Dr. Pappas is accurate. We actually did a mode effect study that we reported to the board a while back where nobody was allowed to practice. We had candidates taking half of the exam on a patient, half of the exam on a confidant. As it turns out, and for this to be an appropriate, realistic simulation with fidelity, that means it's got to reproduce what you do on a human tooth. So that means treating human teeth is all the practice you need. As it turns out, that's in fact true. That being the case, schools still want teeth, this type of tooth, a confidant tooth, where people can practice prior to taking the exam. That was the original request. However, COVID has changed everything, where now schools want these type of teeth to augment their clinical experience, because we can create a tooth with caries any place we want, in any extent we want. So we could create a first molar which had gross caries and an exposure into the pulp, so that you had to remove the caries, debride the pulp, do the root canal, do a buildup, do a crown prep. Now, certainly that's not something we're going to do on an exam, but in an educational environment, that might be quite helpful. So the demands for what the utilization of this tooth and how it's going to be utilized has changed because of COVID. But this is a difficult tooth to produce. It takes a lot of lead time. So the first thing that is going to be released is it's either it'll be in March or April, where schools will be able to purchase anterior and posterior teeth with lesions similar to what we have, but it will not be the same teeth we're using. And they can use it for whatever purpose they have, whether they just want to practice on it or practice for the exam.
Okay, thank you. Appreciate it.
Thank you. Dr. Lai?
Good afternoon, Dr. Champagne, Dr. Pappas. Thank you for joining us today. Two questions. One, if there's going to be a need, for RDA-EF exams, how, and hopefully the way we give our exams in California changes, how long would it take to develop that exam? Number one. Number two.
Dr. Lai, I'm
yes.
sorry to interrupt. This is Karen Fisher. This is off topic.
Okay.
And I think that these questions can actually be submitted offline.
Okay.
So let's plan to do that after the meeting, okay?
Great, thank you.
So if you want to go on to your second question, unless it's related to RDA-EF.
No, it has to do with typodont.
Okay.
That's all. It's okay. I don't need to ask that question. It's okay. Thank you.
Thank you, Dr. Lai. Dr. Morrow has his hand raised.
Thank you, gentlemen, for attending our meeting today and sharing this information with us. This is interesting to all of us, especially to myself as a dental educator. The confidant tooth obviously has some advantages from a clinical training standpoint that regular artificial or typodont teeth do not have. And to use it on a large scale, as far as educational purposes are concerned, I would imagine can be quite expensive. I don't know that, I would like to know what if I was going to purchase typodont teeth for my students to use in their preclinical laboratory exercises, I've got to look at a budgetary constraints, and that can be quite excessive. So I think it's a great idea to be able to provide this to schools or to similar to this, but I have some concerns regarding the economics involved in that. Secondly, I would like to know what your projections are from a standpoint of post-COVID. Do you see licensing examinations such as the ADEX exam ever going back to a patient-based? Is there such a thing as returning to normal, or are we in the process of developing new norms? Thank you.
Thank you, Dr. Morrow. I'll answer the second question, and then I'll defer to Dr. Champagne for the first one, and you can add certainly to the second one. The return to patients will be based on what the dental boards require. Some dental boards are committed to patient treatment, or they have been in the past, and have continued to express a desire to have patients treated in examinations. Other states, such as Connecticut, have determined that they're not going to, even before the pandemic, they had decided to eliminate patient-based treatment. So it'll really depend on the board's feelings. Personally, I think we're trending towards no patients, but we'll provide the examinations that the boards require. Dr. Champagne?
Yeah, I'll start just echoing what you said. I do not see us returning in the future long run to patient-based exams, except as determined and required by specific dental boards. It's already dramatically decreasing. Right now, I think the number is 41 states accept the confidant. At least 20 of those states, it is permanent acceptance. So there's no reason to go back. And I would say as of right now, the ADEX examinations are probably 90 to 95% non-patient based. exam. So I think that the important thing was the Confidant wasn't developed as a response to COVID. This project started 3 years ago. Nobody had heard of COVID. It was to develop a non-patient-based exam that we could test the same principles we needed to test. So the goal was to develop a non-patient-based exam. It just serendipitously was completed at the time that COVID came out. So I think that was the goal, to give that alternative to dental boards. And I think a lot of dental boards have, now that they've had experience with it, have confidence in it. And I just don't see us in the long run. I don't see the future of testing being patient-based. But the second answer, which is important, and basically you're asking how much does a Confidant 2 cost? And my understanding is Accidental charges $14 or $15 for a Confidant 2. So that's about the same that they're, from my understanding, that the endodontic tooth that they charge in the Module Pro. So it's in line. One of the goals that we wanted was to make it economically feasible. The difficulty for dental schools at this point is the amount of work it takes to ramp up production. You know, what we need as testing agencies is a fraction of what dental schools are asking for. But economically, I think that it's going to be a wash, especially as, you know, demand goes up and production goes up, costs go down.
Appreciate that. Thank you very much. And President Pacheco, with your permission, I have one other question that I would like to ask, if that's okay with you.
Yes, Dr. Morrow. Thank you.
Thank you. In your experiences of providing patient-based examinations, and now at least a couple or a few mannequin-based examinations, what do you see as the cost differential in administering these exams? And is there a possibility that the mannequin-based examination could be less expensive to the candidates than the patient-based, the same or more? How do you see the cost of administering the two different examinations compare?
The examination is, thank you, Dr. Morrow. The examination is administered exactly the same as the patient-based exam as far as the number of examiners, floor examiners, all the auxiliary personnel that we use. So in that sense, no, it wouldn't be less. I think because of what happens, as we all know, what happens in the examination process, patients get paid, you know, that sort of thing. I think in that sense, it will be less costly for the candidates.
And I'd like to add, there's a component. See, one of the issues about the Confidant is that no two Confidant teeth are the same. So we could use 8 mesial for every candidate. They would not be the same teeth. There's slight variations in the amount of sclerotic dentin, the amount of caries, the amount of decalcified dentin, stained and unstained, how it promulgates. We wanted that variability. So that requires us to give the exam in the same way, because we can't, they're not uniform. They're not creating an ideal preparation or filling an ideal preparation. We want to be able to evaluate their judgment. So the number of personnel we need is unchanged. Whether I think it's too early to determine what the cost impact will be. It certainly is less for the candidate as far as the patient-based cost, but whether the cost of the exam will go down or even up over time, I don't think anyone knows. Right now, we've probably put about 4,000 candidates through the Confidant exam, so that it's quite a large number. And it looks like the costs as far as administration are the same, because we have increased costs in the materials that we never provided before. So this is all of the Confidant and Typodonts, and every candidate gets a new Typodont that's never been used before at every exam. We provide that. Those are materials we don't have to provide during a patient-based exam.
Okay, thank you very much. I guess I will have to tell my students that they can count on costing the same amount to take the exam. Because a lot of them are hoping anyway that it would reduce the cost. Now, obviously, it will reduce the cost for them needing to pay for a patient to sit for the exam, but not for the cost of the exam itself. So thank you very much. I appreciate it.
You're welcome.
Thank you. This is Board President. Dr. Yu, you had your hand raised.
Yeah, thank you. Thank you for the very interesting presentation. It's a kind of shock to see the performance of some of the dentists. So does ADEC share this kind of information with the school so that maybe they could improve the graduation standard?
Yes, we do. We do communicate with the schools and let them know what's being produced. Certainly.
Thank you.
We actually, as a testing agency, we actually provide pictures. So in the pros and endo, if a candidate is unsuccessful, pictures of that performance go back to the school so they can discuss it with the candidate. Every candidate is required to sign a release that we can provide this material back to their school. As far as the restorative, any school can ask to see the performance, and we arrange to do that. And that's an advantage a confidant has that a patient doesn't have, of course.
Okay, thank you very much.
Thank you. Are there any other board comments or questions? Seeing none, are there any public comments? DCA moderator, please facilitate the lines for public comment.
This is the moderator. We have opened the Q&A panel. If you'd like to make a public comment, please click on the Q&A icon, type "I would like to make a comment" into the field, and then hit send to your hosts. Seeing no requests for comment, would you like me to close the panel?
Yes, please.
It is closed.
Are we able to connect with Dr. Christensen?
I believe so. He is in our attendee list.
Okay.
He had to call in using his phone, so I cannot make him a panelist, but I can unmute his microphone.
Excellent. So now we will move on to agenda item 14A, Western Regional Examination Board Report. And we'll ask Dr. Mark Christensen, Assistant Director of Dental Examinations for the REB, to present this agenda item.
Dr. Christensen, we can hear you. Perfect. Thank you.
Okay. Yes, this is Mark Christensen. I'd like to thank you for this opportunity to update you regarding REB. I apologize for the confusion. During the lunchtime, my power went off, my internet went down, and I was not sure I was able to join the meeting again at all. So I appreciate your patience in that regard. And I would also like to say that many of the things that I will say will reinforce things that Dr. Champagne and Dr. Pappas have already said relative to ADEX. Information about and also I will be shorter. I think I will not take as much time. I don't have a presentation to make, just a verbal report. Information about the REB examination components and format for 2021 already has been sent to you. I can review components for both dental and dental hygiene exams if you'd like, but you should already have this information, and I don't want to waste your time. California has been recognizing the REB dental exam for are familiar with detail of the exam. I would like to remind everyone that all sections of the REB dental exam are conjunctive. All sections must be independently passed, and all sections, including the comprehensive treatment planning section known as CTP, are criterion referenced and examiner graded. Candidates have been taking the comprehensive treatment planning section of their dental exam since last fall. There was major, or not major, but minor backlog at some of the testing locations around the holiday time, but this was due to pandemic-related periods of closure and also upgrading of equipment at some of the Prometric locations. So it wasn't a big thing. Licensing exams were prioritized by Prometric, and the few bottlenecks that occurred were transient and quickly resolved. The practical clinical exams or sections of the dental exam for 2021 now are underway. These include the endodontics, prosthodontics, periodontics, and operative dentistry sections. Most graduating dental students who take the exam will be challenging it during the next few months, so between now and June, pretty much. Most test sites have implemented precautionary protocols and now are accustomed to operating during the pandemic. So we're finding that the exams for 2021 are not being canceled or postponed. The exams are being firmly scheduled and will not be strung out like they were last year. Although a patient and simulation formats are available for both the dental and dental hygiene exams, the predominant format for REB exams this year, again, like for ADEX exams, will be simulation. And simulation quality now is improving every year. Ongoing field testing of technical innovation and annual implementation of simulation improvement looks like it's going to be with us going forward. As many of you know, the pandemic has accelerated change. Some of it was in development anyway, and some of it was unexpected but necessary to accommodate restrictions and mandates imposed by the pandemic. This year, the simulation for REB's operative dentistry section especially has improved over last year. This year it involves radiographic interpretation. The teeth have simulated dentin and enamel and an easily discernible DEJ. The simulated caries is variable. It provides tug back and sufficiently extends into dentin that it requires the candidate to initiate a modification request in every instance. The teeth also have simulated pulp tissue, and pulp exposure is a potential risk. We see on the exam that, in fact, candidates make the same mistakes that they seem to make with patients. Engineers working on simulation now are developing additional improvements for 2022. We all should now just expect, I think, that ongoing improvement in simulation will occur as we move forward. While simulation does not assess everything that can be tested when there is a patient, it clearly can be more highly controlled and standardized. And Dr. Champagne was talking about that. It's no walk in the park. Simulation obviously tests candidates' dexterity, coordination, indirect vision, and ability to translate conceptual understanding into physical performance. The standardization also makes it easier for examiners to grade. Inter-rater agreement, which was high before, I think on patients for REB, it was around 88%, is even higher now with simulation at something like 91%. It's moved a little higher. Simulation results are highly discriminating, as you probably saw with some of those slides that were presented a moment ago by ADEX. And in many ways, the results seem to parallel those that we see with assessment for performance with patients. While design of the simulated sections enables REB to grade the exam either remotely or on-site, the good news is that now most examiners have received the vaccine. This, coupled with the recent reduction in the frequency of positive COVID tests, causes us to expect that REB will be able to accomplish grading with a full team of examiners on-site for all exams and at all sites this year. There's no question that the pandemic and accompanying restrictions have variously impacted dental education, or at least the number of patient-facing experiences students have had at some programs during the past year. Programs have compensated for this in a variety of creative ways, which that's great, and for which they should be commended. But under these circumstances, entry-level competency assessment, despite its limitations, perhaps has never been more important. It is only one aspect of qualification, but it does help ensure that the applicant is, in fact, ready for independent practice. Again, detailed information about dental and dental hygiene exam components and format has been sent to you. The REB would be happy to make a presentation with slides and images of candidate performance if you would like, and present more detailed statistical results for last year and the year before, comparing the results of pass, fail in various sections and for simulation versus patient-based assessments. and I can mention some of those if there are questions. I would like to share that REB now is field testing the few remaining components of a new practical clinical examination for dental therapy. This exam will likely be ready for release later this year. And I would like to especially thank program administrators, faculty, and staff at UOP, the University of the Pacific, for their support in beta testing some of the new simulations. And lastly, I would really like to thank the California Board for their support in making California licensing requirements clear for applicants last year and now for 2021. If there are questions, I'd be happy to attempt to answer questions. You can also send questions anytime to dentalinfo@reb.org. That's dentalinfo@reb.org, and you'll receive a timely response depending on your question from whoever is most knowledgeable. And this concludes my report.
Thank you, Dr. Christensen, for your very in-depth report. I do see a board member comment or question by the raised hand of Dr. Yu. Dr. Yu, did you have a comment? Dr. Yu, you have the raised hand feature showing on the screen. Are there any other board member comments or questions? Dr. Morrow?
Thank you, President Pacheco. Thank you, Dr. Christensen, for joining us today. I appreciate your tenacity in staying with us and being able to make contact. I appreciate the long number of years that we've had relationship that the dental board has with the REB examination. And I just want to say that I'm delighted to hear that the upcoming examinations will be graded on site rather than distance. I think that's an important component for our candidates that are taking the examination. The other thing that I was interested in was the comparison, the 90%, 91% grading similarity between the two examinations. Could you give me a little bit more information on that from a standpoint of you're comparing the mannequin-based or the simulated exam to the live patient exam and that 91% similarity?
Yeah, well, yes. What I was talking about was examiner agreement, inter-rater reliability. So for the patient,
inter-rater reliability. Fantastic.
Yes,
okay.
And this is for the operative section. The patient-based operative section has had around an 88%. I think in 2019 it was 88.2% of inter-rater reliability, the way REB calculates that. And the percentage of examiners that were harsh or lenient, leniency was 5.8 and harsh was 6.0. So for the mannequin, the inter-rater reliability went up to 91%. It's a little bit of an increase there. And on both extremes, the harshness and leniency went down to around 4.5%, 4.3 and 4.7%. So that's really not surprising, given that although there's variation with those teeth that were used last year and will be used this year, some of the teeth require more modification requests than others. They all require modification requests. And this coming year, and but we see that it's easier for examiners to look at the results of candidate performance and discriminate that performance. That's all.
Okay. Thank you very much. I appreciate your time sharing with this information with us.
I can also share with you that for the exam overall, REB's pass rate is around 84, 85%. Candidates have to pass every section in order to pass the overall exam. They have to pass every section that they challenge. And the pass rates for the individual sections are higher than 85%, but the overall pass rate by attempt is about 85%. By
And
the
what
end of
is
the
your-
season, by the end of the
Sorry.
season, when people who failed one portion or another remediate and re-challenge those sections, the pass rate improves. So by candidates at the end of season, it's more like around 97% or 97 or 98%. Ultimately, in the end, after candidates remediate and retake sections of the exam, in the end, we are eliminating a very small percentage, but a small percentage of candidates who have repeatedly demonstrated that they're not yet ready for independent practice.
If you said it, I missed it. What is your pass rate for first time attempt?
First time attempt, it's around 80, it depends on the cohort that we're looking at. But overall, by attempt, it's around 85%, 85 or 86%.
Okay, thank you very much. I appreciate it.
This is Board President. Are there any other comments from the board? Are there any public comments? DCA moderator, please facilitate the lines for public comment.
This is the moderator. We've opened the Q&A panel. If you'd like to submit a comment, please click on the Q&A icon on your screen, type "I would like to make a comment" into the text field, and send that to the hosts. Our first request for comment comes from Megan Utter. Megan, your line is open. You will have 2 minutes.
Hi there. Good afternoon, board members. I'm hoping I'm in the right agenda section to pose this question. If not, I can wait until 15A. Like mentioned, my name is Megan. I'm a dentist in Iowa right now, set to complete my orthodontic residency in June of 2021. Due to COVID, the board has made some significant, as well as through REB, made some significant accommodations to licensure through the REB pathway, specifically for dental students with the approval of the mannequin-based clinical examination. My question I pose today is if, whether it be through REB or the board, there's such a leniency or accommodation that have been considered for other licensure pathways. For example, opening the window of the ADEX examination and allowing dental specialist residencies like myself as an acceptable means for licensure, or assessing on a case-by-case basis whether some type of accommodation can be made. My current situation, just very quickly, I know my time might be running up. I'm in a specialty program in Iowa and took the ADEX examination in March of 2019, making myself ineligible to apply for licensure through ADEX. I was prepared to take the REB examination, the mannequin-based one, of course. However, I'm not permitted to travel to take the REB due to COVID travel restrictions through my dental school. So thus, at this point, I have no means to apply for licensure through the state of California, and I'm wondering again if any accommodations can be made through REB or within the board. Thank you.
Seeing no additional requests for comment, would you like me to close the panel?
Yes, please.
It is closed.
Thank you. And now we will move on to agenda item 15A, review of dental licensure and permit statistics. I'm going to ask Jessica Olney, manager of the anesthesia unit, to please report on this agenda item.
Thank you, President Pacheco, and thank you, board members. Page 133 of the agenda packet is agenda item 15A, the dental licensure permit statistics. You'll see the first few pages, we offer a breakdown of the applications, and those are broken down by the different pathways, which are licensure by REB, licensure by residency, licensure by credential, licensure by portfolio, and licensure by ADEX. And these are broken down by fiscal year, and we're going back the last 3 fiscal years. Those include statistics on applications received, applications approved, licenses issued, applications canceled, applications withdrawn, and applications denied. And so far, we can provide data through December of 2020. If moving forward to page 136 of the material, we have the dental law and ethics written examination statistics for the past 3 fiscal years, or excuse me, the current fiscal year and 2 previous fiscal years. These are also broken down by licensure pathway, which include the licensure by REB, licensure by residency, licensure by portfolio, and licensure by ADEX. Licensure by credential is not included as the examination is not required for applicants who are qualifying through that pathway. The last occupational analysis of the written examination was completed in 2018 by the Office of Professional Examination Services, and a target date for the next occupational analysis is in 2025. And then we have, beginning on page 137, we have the dental license and permit statistics. The first table that you see is a breakdown of, again, the different pathways to licensure for fiscal years 18-19, 2021, or excuse me, 18-19, 19-20, and 2021. These are broken down, again, by the different pathways, and you'll also see that licensure by credential is broken down by in addition to applicants who have qualified by credential, also by applicants who have qualified with a pending contract. The next set of tables, continued on page 137, is the individual license and permit statistics. For the dental license, we include statistics on active, inactive, the retired reduced fee, disabled, delinquent, and canceled licenses. For the following permits, we provide data on active, delinquent, and canceled permits. You'll notice by the number of the canceled licenses, that is the number of licenses and permits canceled to date. Moving on to page 140, we provide the fiscal data on licensed dentists per county, and this is a breakdown of active licensed dentists per county, and it's broken down by the dentists, the number of population, and the ratio of dentists per population. Page 142 provides a breakdown of the counties with the highest population per dentist, and also a breakdown of the counties with the lowest population per dentist. And this information is provided as informational, and no action is needed, and I'll refer to any questions.
Are there any questions of the board members? I see none. Anesthesia manager Jessica Olney will present this item, provide background information at this time.
Okay, thank you. Just to go back, do we need to ask for a public comment on agenda item 15A?
Yes. Moderator, please facilitate the lines for public comment.
This is the moderator. We have opened the Q&A panel. Again, if you'd like to make a comment, please click on the Q&A icon, type "I would like to make a comment" into the Ask field, and submit that to the hosts. Our first request for comment comes from Kelsey Patel. Kelsey, your line is open. You will have 2 minutes.
Hi, I just had a question about the chart on page 137. It gives the total number of ADEX licensures that have been granted to date, but it looks like in the columns indicating the year in which those were accepted, there was only 77 in 20 and 21 and 1 in 2019, 2020. So I'm just wondering where those kind of remaining like applicants, when they received their license via ADEX, according to the column that indicates that there's 139 to date.
Thank you, Kelsey. And seeing no additional requests for comment, would you like me to close the panel?
Yes, please.
It is closed.
Thank you. We will now move on to agenda item 15B, general anesthesia and conscious sedation permit evaluation statistics. I'm going to ask Ms. Olney to please report on this agenda item.
Thank you. Thank you, President Pacheco. Beginning on page 143 is agenda item 15B. This is a breakdown of the general anesthesia and conscious sedation permit evaluation statistics. The agenda item also has been broken down by fiscal year to include previous fiscal years of examination or evaluations. We also wanted to note that there has been a decline in the total number of evaluations that have been scheduled and completed in the 2019-20 and 2021 fiscal years. This can be attributed to the COVID-19 state of emergency which was issued by the governor. The board has had to make several adjustments to the evaluation program, which began at the beginning of the pandemic with scheduling and canceling and essentially rescheduling several of the evaluations. But if you look on page 144, we begin with the breakdown of the general anesthesia evaluation statistics. The first table is a breakdown of the evaluations that have been scheduled, or excuse me, passed, failed by simulated emergencies, canceled by request by the permit holder, or the permit was canceled for noncompliance, the evaluation was postponed due to no evaluators being available, or postponed by the permit holder. The second table will show a breakdown by fiscal year of those different categories as well. Page 145 provides the same information for the conscious sedation permit for the last year. Second table also breaks that information down by fiscal year. Page 146 provides the information for the medical general anesthesia permits. And again, for the year, second table will break it down by the previous fiscal years. And page 147 is a breakdown of the evaluators that are available per region. So that is broken up between Northern and Southern California. And we have evaluators in different categories for general anesthesia, conscious sedation, and medical general anesthesia. Again, no action is requested, and this data is provided for informational purposes. And I'll refer back if anyone has any questions.
Do any of the board members have any comments or questions? Seeing none, are there any public comments? DCA moderator, please facilitate the lines for public comment.
This is your moderator. We have again opened the Q&A panel. If you'd like to make a public comment, please click on the Q&A icon on your screen. Type, "I would like to make a comment" into the text field and send that to the hosts. Our first comment comes from Dr. Bruce Witcher. Dr. Witcher, your line is open. You will have 2 minutes.
Thanks for presenting these statistics. It's an area that I've tracked for a long time. I guess the one good thing is it does look like the number of evaluations scheduled is picking up. We're certainly not back where we'd like the program to be, but I think it's headed in the right direction. I know I've personally gone out and done a number of evaluations just in the last couple of months, so
I think if everybody, pitches in and gets them done, we'll be able to get the program back where it needs to be. So thank you.
Thank you, Dr. Witcher. Seeing no additional requests for comment, would you like me to close the panel?
Yes, please.
It is closed.
Thank you. We will now move on to agenda item 15C, update on implementation of Senate Bill 501, Glacier, Chapter 929, Statutes 2018, Dentistry, Anesthesia, and Sedation Report. I'm going to ask Ms. Olney to please report on this agenda item.
Thank you, President Pacheco. Beginning on page 148 of the agenda material is agenda item 15C regarding SB 501, which was signed by Governor Brown in 2018. This legislation will become effective January 1st of 2022 and impacts the general anesthesia, conscious sedation, and oral conscious sedation permits. As a result of this bill, the board will need to make significant changes to the current anesthesia and sedation program. And those changes will include the introduction of a pediatric endorsement and patient monitoring requirements when administering anesthesia or sedation to a minor patient. The legislation also added Business and Professions Code 1647.30, which will require the board to create a new pediatric minimal sedation permit. Below is a breakdown of the impacts we believe will affect each individual permit, which will be the naming conventions, things that will need to be done by board staff in order to implement these new changes. The board will need to promulgate new regulations to update current requirements to meet the updated legislation, and staff is currently working with board legal counsel on the development of draft language and plans to present the language to the board for consideration at a later meeting. Additionally, SB 501 does require that the board make available data on adverse events related to general anesthesia, deep sedation, moderate sedation, and minimal sedation, as well as relevant professional guidelines, recommendations, and best practices. That information is required to be presented to the legislature by January 1 of 2022. The board staff is currently working on the report and will also provide this information in the latter half of 2021. This information, again, is informational and no action is requested. So I'll refer back to President Pacheco if there are any questions or comments.
Thank you, Ms. Olney. Are there any board member comments? Please use the raise hand feature. Seeing none, are there any public comments? DCA moderator, please facilitate the lines for public comment.
This is the moderator. We've opened the Q&A panel. If you'd like to make a public comment, please click on the Q&A icon on this screen. Type "I would like to make a comment" into the text field and submit that to the hosts. Seeing no requests for comment, would you like me to close the panel?
Yes, please.
It is closed.
Thank you. We will now move on to agenda item 15D, update on AB 2113, Low, Chapter 186, Statutes of 2020, Refugees, Asylees, and Special Immigrant Visa Holders, Professional Licensing, Initial Licensure Process. I'm going to ask Ms. Olney to please report on this agenda item.
Thank you, President Pacheco. Beginning on page 150 of the agenda materials is agenda item 15D, which is an update on AB 2113. This is a bill that was signed by Governor Gavin Newsom, which added Business and Professions Code 135.4. This requires requires boards within the Department of Consumer Affairs to expedite initial licensure processes for applicants who meet certain criteria. These are granted to applicants who are refugees or have been granted asylum or a special immigration visa. In order to qualify for the expedited licensure process, individuals must provide documentation of their refugee, asylee, or special immigrant visa when submitting their application package. Since the implementation of this in January, the board has made changes to update all of their applications, which are available on the website, as well as made updates to the brief system to include questions which ask applicants if they are requesting an expedite of their application. To date, the board has not received requests for an expedited application. We have received requests for information, and we monitor for any applications received. And again, this information is informational and no action is requested. Thank you.
Thank you, Ms. Olney. Are there any questions or comments from the board members? Dr. Montel, I see that your hand is raised.
Yes, hi, thanks. This is Alicia Montel. I just had a question about the special immigrant visa with the classification code of SI or SQ. Is there a little more clarity on what that means?
Thank you. No, I do not have information on what that is, but we can get that information.
Thank you.
Are there any other questions or comments from the board members? Seeing none, are there any public comments? DCA moderator, please facilitate the lines for public comment.
This is the moderator. If you'd like to make a comment, please click on the Q&A icon on your screen. Type "I would like to make a comment" into the text field and submit that to the hosts. And President Pacheco, Dr. Bruce Witcher actually submitted a request just as we closed out the panel this last time, so I'm going to take him first.
Thank you.
Dr. Witcher, your line is open. You will have 2 minutes.
Yeah, this had to do with the implementation of SB 501. It's clear we're not going to make the January 1, 2022 deadline with new regulations because that process usually takes at least 2 years. And I think the board has pretty much gone on record as informing the legislature and everybody involved that we were operating under probably what I would call an unrealistic time constraint. So just a word about that, and that's really all I have to add. Thank you.
And seeing no additional requests for comment at this time, would you like me to close the panel?
Yes, please. And thank you. We will now move to agenda item 15E, update regarding paperless renewals beginning July 1st, 2021. I'm going to ask Ms. Olney to please report on this agenda item.
Thank you, President Pacheco. On page 152 of the agenda materials is agenda item 15E, which is an update on the paperless renewals. The board, or excuse me, staff first presented to the board in November of 2019 the idea of converting to paperless renewals for all licenses and permits that are issued by the Dental Board of California. Since then, the board staff have worked with the department as well as Bree's team to work on implementing those changes. And we look to begin accepting the online-only renewals beginning with the July 1st, 2021 renewals. What that means is that beginning in, the first week of May, the board will start mailing out paper postcards to all licensee and permit holders, informing them that it is time to renew, and the board will no longer send the current 8 to 10 page paper renewal. Board staff have worked with the department to all licensees of the changes. We've worked with the Office of Public Affairs, Publications, Design, and Editing to create a web page that draws attention of our licensees. Staff have also continued to send email notifications to all registered email addresses. And we have also reached out to stakeholder groups and asked that they share the information on their social media or website pages. Again, this will begin with the July 2021 renewals. And again, the board will no longer send the paper renewal, but it will instead send a postcard letting licensees know that it is time for them to renew. We ask that all licensees please log into Breeze if they have never used the system before and create an account in order to link their license in order to avoid any issues rather than waiting until it's time to renew to set up their accounts. This information or this agenda item is informational. No action is requested, and I'll refer back to President Pacheco if there are any questions or comments.
Thank you, Ms. Olney. Are there any questions or comments from any of the board members? I see Dr. Montel, your hand is raised. Is Dr. Montel still connected? Oh, there she goes. Okay, thank you. Seeing none, are there any public comments? DCA moderator, please facilitate the lines for public comment.
This is the moderator. We've again opened the Q&A panel. If you'd like to make a public comment, please click on the Q&A icon on your screen. Type "I would like to make a comment" into the text field and submit that to the hosts. Seeing no requests for comment, would you like me to close the panel?
Yes, please.
It is closed.
Thank you. And this would be a wonderful time to take a 15-minute afternoon break. It is nearly 1:40. Would it be appropriate, Ms. Fisher, to resume the meeting at 1:55?
Yes.
Okay, 15-minute break. Thank you, everyone.
introduced at the deadline and after our agenda was put together, these are not items that we will discuss at this time. But board staff will be preparing analyses and information on this bill, on these bills that will be available to you later on. I also wanted to make you aware under this section that, and this is especially for new members, most of our items fall under the business and professions committees of either house. And the Senate Business and Professions Committee now has a new chair and vice chair. The new chair is Senator Richard Ross from Riverside, and the vice chair is Melissa Mendez. That's all I have to report on this item. I'd like to know if there are any board member questions or comments. Seeing none, are there any public comments? DCA moderator, please facilitate the lines for public comment.
This is the moderator. We have opened the Q&A panel. If you'd like to make a comment, please click on the Q&A icon on your screen. Type "I would like to make a comment" into the text field and submit that to the hosts. Seeing no requests, would you like me to close the panel?
Yes, please.
It is closed.
Okay, so we will move on to item 16B, discussion and possible action on SB 102 Melendez COVID-19 emergency order violation, license revocation. Since this item has been placed in our agenda, this bill has been amended and no longer pertains to the dental board. So we will not have any discussion on this item. Are there any board member comments? Please use the raise hand function. Seeing none, are there any public comments? DCA moderator, please facilitate the lines for public comment.
This is the moderator. We've again opened the Q&A panel. If you'd like to make a comment, please click on the Q&A icon on your screen. Type "I would like to make a comment" into the text field and submit that to the hosts. Seeing no requests, would you like me to close the panel?
Yes, please.
It is closed.
Our next item is item 16C, update on board legislative proposals. Wilbert, would you like to present this item?
Yes, thank you, Ms. Burton. Good afternoon, board members. This is Administrative Services Manager Wilbert Rumbawa, and I will be providing an update on the board legislative proposals. The Dental Board has directed staff to submit legislative proposals and seek authors for the following issues. At the December 2020 meeting, board staff submitted a legislative proposal to clean up existing language by amending Business and Profession Code 1724 and adding the maximum and renewal fees for the newly created pediatric minimal sedation permit. This language set the maximum fee at $1,000 and the renewal fee at $600. This is equivalent to the fees for the other anesthesia permits. Item 2, at the August 2020 meeting, the board acknowledged the challenges with the administration of the RDAEF clinical and practical examinations. As a result, the board directed staff to seek an author to carry legislation to repeal the requirements of the RDAEF clinical and practical examinations permanently. Board staff have submitted these legislative proposals to the Senate Business, Profession, and Economic Development Committee in early January. Board staff have had discussions with the Senate BP and ED Committee consultants and Senate Republican Caucus consultants to present the proposals and address any questions. The BP and ED Senate consultants are assisting board staff with identifying authors and appropriate legislative vehicles for both proposals. No action is required at this time.
Thank you. Are there any board member comments?
Board Member Burton, this is Sarah Wallace. I would like to share a quick update, if I may.
Okay.
Since the publication of the board meeting materials and the deadline, we have become aware that a bill was introduced by Senator Roth to take on the board's proposed amendments relating to the RDAEF exam, and we are still waiting on the bill number relating to the fees for the pediatric minimal sedation permit. And that the bills will be presented at future meetings.
Thank you. Any board member comments? Any public comment? Going to ask the moderator to please facilitate this.
This is the moderator. We've opened the Q&A panel. If you'd like to make a comment, please click on the Q&A icon on your screen. Type "I would like to make a comment" into the text field and submit that to the host. Our first request for comment comes from Dr. Bruce Witcher. Dr. Witcher, your line is open. You will have 2 minutes.
Yes, I'd just like to comment on the legislative proposal to clean up the pediatric minimal sedation permit. In addition to omitting the fees, the original bill also omitted any continuing education requirement for that permit category. All the others have a CE requirement. And I wonder, since this was originally submitted as an omnibus proposal and is now going to have its own vehicle, if that might present an opportunity for cleaning up the continuing education aspect of that permit. Thank you.
Seeing no additional requests for comment, would you like me to close the panel?
Yes, please.
It is closed.
Okay. We're going to move to item 16D, discussion and possible action regarding California Dental Association's legislative proposal for 2021. I am going to ask Mr. Ramboa to present this item and to make you aware that CDA will be available to answer any board questions.
Good afternoon, board members. Wilbert Rambawa to report on the discussion and possible action regarding the CDA's legislative proposal for 2021. CDA, the California Dental Association, previously submitted similar language for clinical laboratories in AB 613 in the previous year, but the bill died. For the new legislative season, CDA is sponsoring AB Assembly Bill 526 for clinical laboratories to include the authorization of dentists to independently prescribe and administer influenza and COVID-19 vaccines approved by the Food and Drug Administration for persons 3 years or older. In addition, it would also expand the definition of a laboratory director. There is no action being requested at this time.
CDA, do you have any comments? Is there a representative from CDA?
Hi, yeah, this is Mary McCune from the California Dental Association. If I could, I'd like to go in a little bit more detail around AB 526. So I think we've already talked about the laboratory licensing issue, but since there's been a couple of new dental board members added since our last discussion, I'll very briefly go over that. Essentially, what this portion of the bill, this is the first half of the bill, it would allow dentists to be able to administer point of care rapid testing for COVID. That's the intent of the bill. The only thing is that even though dentists are able to do this, not only because it's in their scope of practice, but also at the federal level, they're able to do this. Unfortunately, the state lab testing laws in California that regulate the ability to do this test don't actually delineate that dentists can do that. So what this bill would do is essentially create parity with federal and state laws so they can get those requisite lab licenses in order to administer point of care rapid testing. And this is caveated by the fact that this is really for when rapid testing technology is to the point that it's appropriately accurate, affordable, and easily accessible. And so that arguably would not be right now. So this is really in preparation for that time once technology catches up. The second part of the bill is essentially partially codifying the DCA waiver that allows dentists to prescribe and administer the COVID vaccine. It goes a little bit further and also includes flu vaccines as well. And this is for ages 3 and over. This would also allow for dentists, first it would allow that any CDC courses that have been taken in due to the requirements of either the DCA waivers or for CDPH requirements to administer the COVID vaccine, that those would be retroactively and going forward count towards continuing education for license renewal. And so that's done essentially because CDC is not a registered CE provider. They're not PACE or CERP, although in the near future, they plan on trying to become CERP certified. But what the language in this bill does would basically look at CDC courses that fit within the scope of practice of dentistry to be admitted as appropriate CE, similarly to how the dental board views the American Heart Association or the American Red Cross for BLS courses. And then additionally, it would say that going forward, dentists would either have to take a CDC course or a course that covers specified curriculum by any registered CE provider to maintain the ability to administer vaccines going forward. And then lastly, we're looking at future amendments that would extend the CDC courses to count retroactively. That's not in the bill right now, but we're looking at amending that in the next committee. And that we're also looking at including, we'd like to talk to either Ledge Council or dental board staff to see whether or not we could include as part of this having the courses that RDHs have to take, the CDC courses specifically, to also administer the vaccine, because another DCA waiver was published a couple weeks ago allowing RDHs to administer the COVID vaccine. And since the registered CE providers are still, that registration process is still done through the Dental Board of California and not the Dental Hygiene Board of California, we thought it might be more appropriate to have that type of code section included in this bill. And so with that, I'm available for any additional questions from the board about this bill. Thank you.
Ms. Burton?
Yeah, I'm still here. I'm available for any questions at this point.
Okay. I was asking if you would go back to the beginning of your last comment. You were considering future amendments to extend what? What did you say?
To extend that the CDC courses, right now it's just specific to the very first dental or dentist waiver to administer COVID vaccines. Since then, there's been a waiver that was published that supersedes the first waiver. But because the language is very specific to the actual number of the waiver, we needed to include that waiver. And then also, because we do anticipate that the CDPH will provide additional guidance for dentists to administer COVID vaccines in their own dental practices once vaccine dosage has increased and stabilized, that additional training might be required. So we wanted to really be clear that it's the first or the second waiver or any other future subsequent waivers, any of the training for that will count towards CE, but largely just CDC courses in general, if they're taken within the scope of practice of a dentist, should count as CE, similarly to American Red Cross or American Heart Association.
Thank you. At this point, I would like to open this to board member comments. But prior to doing that, I wanted to make particularly the new members aware that it has been my practice not to take a support position on bills that had not had a hearing in committee. And more so in this case where there is some anticipation that there will be some additional amendments to the bill. And so it would be my recommendation that we not take a position on this time. And having made that comment, I want to recognize Dr. Felsenfeld.
Thank you, Ms. Burton. Felsenfeld, board member. Having said that, that you've just said that, I will yield to that, but I would like to suggest that this is an excellent bill and one that I think many of our dental colleagues will jump on once we get the go-ahead to be able to do that. It's a wonderful thing to do for our patients. Any dentist that gives injections for anything can certainly give an intramuscular injection. It is not difficult, having done that myself many times. We have a series of dentists, including pediatric dentists and periodontists and general dentists that do moderate sedation and oral and maxillofacial surgeons who would be very, very willing to do that. I would have suggested a support. I respect your comments, but I think we should at least watch it, hopefully.
Oh, we certainly will. We certainly will do that. Are there any other board member comments? Are there any other board member comments?
Dr. Morrow has his hand up.
I'm sorry. Whose hand is up?
Dr. Morrow.
Oh, Dr. Morrow?
Yes, thanks. I was just wanting to ask, and as long as we have Mary McCune on here too, is this a possible vehicle for approval for dental students in dental schools in California under proper supervision of their trained faculty to be able to provide the vaccine?
Yeah, I can respond to that. Right now, we're in discussions with DCA and the governor's office to see whether or not dental students, it's a little hard because dental students are not licensed, so their purview under DCA is a little bit different than how a licensed dentist would be viewed. That being said, we are looking at how dental students can be utilized similarly to medical assistants who are unlicensed yet in their statutory scope. It's very clear that with appropriate training that arguably dental students exceed with, they are able to, under direct supervision, administer vaccines. So using that pathway, we're looking at a potential next step there.
Well, just so that you'll know, my university opened a community COVID vaccine clinic on campus in cooperation with the San Bernardino County Department of Public Health. And our pharmacy students are allowed to administer vaccines at this clinic. Our nurse practitioner students are medical students, but our dental students are not allowed to. And there seems to be some inconsistency there from a standpoint of what students can do when they're being supervised by their faculty and what other students cannot do. So I don't understand for sure why the discrimination is taking place.
Oh, that being said, I will
Okay,
say that
excuse me, Mary.
once-
Mary,
oh, sorry.
excuse me. Thank you, Dr. Morrow. That was not related to the legislation that we're currently discussing. So this sounds like an issue that probably needs to be discussed outside of the board meeting, and I'm happy to have that discussion with Mary at a later date. We're discussing specifically.
If I stepped out, I apologize.
Yeah, apology accepted. You did step a little bit over the line. So we're talking about AB 526.
I would add
But
that
again,
if
I was
AB
asking if this was a vehicle that could be amended to carry something of that extent.
Again, I think that kind of conversation needs to be offline, if you will. And I think, Mary, at this point, your response needs to be offline. We're looking at what the current bill says.
right, and if this is my response would be in what is in print right now.
Yes, and this is an example of why Member Burton had said she would prefer not taking a position on the bill, because it's likely that it could be changing a couple of times. So thank you for everybody's comments.
Could I respond to say how this bill would take effect if passed, though? That I think would address Dr. Morrow's question. Essentially, if this bill is passed as written right now, dental students would be able to administer vaccines because it's a part of the permanent scope of dentists. So they'd be treated the same way as pharmacists and other graduate students because it's a part of the scope of practice of a licensed professional of whatever they're studying.
Thank you. I want to recognize Dr. Montel, please.
Hi, thank you, This is Alicia Montel. Just to clarify again how this would be used, it's my understanding, and please correct me if I'm wrong, that the state needs to approve, because we have been saying that the dentist can now, with this, if this passes, the dentist can give vaccinations out of their offices, but it's my understanding that the state has to approve a vaccination site before you can give a vaccination there. So I just want to see if I can clarify that this proposal is really going to clear the way for dentists to be able to go to more of a mass vaccination setting or a large school that's gotten the designation by the state as a vaccination site to give those vaccines, and we're not really looking at individual offices being able to give them out as a result of this, or is that something that you can clarify?
I'm going to respond and say that I think that we need to look at what the amendments are. It's kind of impossible to answer that question right now.
Okay. Okay, we will.
We just need to continue to monitor this.
Okay. Great, thank you.
Are there any other board member questions or comments? Are there other public comments? And I'm going to ask the moderator to facilitate that function, please.
This is the moderator. We have opened the Q&A panel. If you'd like to make a comment, please click on the Q&A icon on your screen. Type "I would like to make a comment" into the Ask field and submit that to the host. Member Burton, at this time, I don't see any requests for comment. Would you like me to close the panel?
Yes, please.
It is closed.
Thank you. Our next item is item 16E, discussion of prospective legislative proposals, page 173. And again, for the information of new members, some years ago, we added this as a way for stakeholders to submit proposals in writing to the board before or during the meeting for possible consideration by the board at a future board meeting. And I don't believe we have anything, and no action is requested on that item. And so with that, I am going to turn this back to the president, please, for item 17.
Thank you, Ms. Burton. We will now move on to agenda item 17A. Review and consideration of comments received during the 45 day comment period and proposed responses thereto for the board's proposed rulemaking to amend California Code of Regulations Title 16, Section 1020.4 relating to diversion evaluation, committee membership rulemaking. I will ask Wilbert Rambawa, Administrative Services Manager, and Danny Rogers, Board Regulatory Legal Counsel, to present this agenda item.
Thank you, Board President. At the February 2019 meeting, the board approved regulatory language to update requirements for the Diversion Evaluation Committee membership. There are two sections that were being asked to be amended. Section 1020.4A to no longer require one licensed dental auxiliary and to increase the number of public members to 2 instead of 1, and to amend Section 1020.4C to delete the limitation for DEC members to only serve 2 4-year terms. The board noticed the regulation proposal on November 20th, 2020, and gave the public 45 days to provide public comment, which ended on January 5th, 2021. No public hearing was requested or conducted, but the board did receive a public comment, which is on page 177 of your materials. On November 22nd, 2020, the board received an email from Dr. Tien Vu on the proposed amendment to 16 California Code of Regulations 1020.4. Below are the board's proposed responses to the comments made. The comment originally states disapproval of the proposed regulations because they will remove the term limits for serving on the DEC, which will result in DEC members serving for too long and not being responsive to the needs of the public interest which they serve. The commentator believes that the positions have not been adequately advertised and that such adequate advertising would negate the need for this rulemaking. The commentator also asserts that having a guaranteed position on the DEC will foster complacent and trading favors. Staff's recommended response to the comment is as follows. Staff have reviewed and considered the comment and do not recommend any amendments to the language based therein. The board proposed the amendments to section 1020.4 because the board historically has had difficulty maintaining complete membership of the DEC. Removing the term limitation will allow DEC members to complete the committee's important work without ending the members' terms when they are still willing to serve. The board finds the concern that DEC members who serve too long will be complacent and trading favors unfounded. The DEC only makes decisions regarding individual licensees who have voluntarily come to the DEC for help with substance abuse problems and does not make decisions regarding policy or spending. DEC members are also required to file annual statements of economic interest, which is a standard transparency disclosure required of all elected officials and public employees who make or influence governmental decisions. Furthermore, the board has the power to remove a DEC member who is failing in their duties on the DEC. Furthermore, As described in the initial statement of reasons, the problem with filling these positions turns on the structural differences between the dental auxiliary position and the other positions. Individuals holding other positions may have professional reasons for experience with substance abuse and are more likely to be highly compensated professionals as dentists and therapists, for instance, and business owners. Auxiliaries tend to have lower salaries, must coordinate their schedules with their employers, and may be concerned about their employers knowing about their experience with substance abuse. For these reasons, DEC has had substantially more difficulty filling these positions than the other DEC positions. This is the motivating factor behind the proposed rulemaking.
Are there any board? I'm sorry.
Oh,
go ahead.
Go ahead. I believe Ms. Rogers is here. If there's any questions regarding the 45-day comment period.
Hi, this is Danny Rogers. I'm available to take any questions.
This is the board president. Are there any comments from any of the members of the board?
President Pacheco, this is Sarah Wallace. May I provide a clarification?
Yes, please.
So in terms of process, I know this process is new to several of our board members. It's been quite a while since we've had a rulemaking that's gone through the 45-day public comment period. But the board is responsible for responding to any adverse comments that we receive after a 45-day public comment period. And so what we're presenting here today is the single comment that we received in relation to the Diversion Evaluation Committee membership rulemaking. And in the board meeting packet, what Wilbert just went over was a summary of what the comment was and then what the staff recommendation for the response is. And so he summarized it, but you'll see on pages 175 through 176 of the meeting materials that it goes into great detail and justification, which is required when we are responding to comments to provide the rationale because it becomes part of the rulemaking record. And so this agenda item at this point, we're asking for the board to take action to accept, reject, or modify the staff recommended response to this adverse comment. If the board rejects or modifies staff's recommended response, then we ask that the board provide a rationale, a detailed rationale for us to include in the rulemaking final statement of reasons. And so this is a two-part agenda item. We have 17A and then 17B. So at this point for 17A, if the board agrees, the action we are seeking is for acceptance of the staff recommended response to the adverse comment. And we'd be happy to answer any questions.
And I see two hands that are raised. Ms. McKenzie?
I was just going to move to accept the staff's recommended response.
Thank you. And Dr. Stewart?
Yeah, as a DEC liaison, I was going to do the same. I'm very pleased to second that motion.
Okay, thank you. So the motion is acceptance of staff recommendation. Are there any other comments? Are there any public comments? DCA moderator, please facilitate the lines for public comment.
This is the moderator. We have opened the Q&A panel. If you'd like to make a comment, please click on the Q&A icon on your screen. Type "I would like to make a comment" into the text field and submit that, and we will pause for a brief moment. Seeing no requests for comment, would you like me to close the panel?
Yes, please.
It is closed.
Thank you. Board Secretary, please call the roll and record votes for this agenda item.
This is Felsenfeld, Board Secretary. We're now considering item number 17A, Diversion Evaluation Committee Membership Rulemaking. The motion is to accept the staff recommended response to the comments. Burton.
Burton, aye.
Burton, aye. Felsenfeld, aye. Lai.
Lai, yes.
Lai, aye. Laureen.
Laureen, yes.
Laureen, yes. Mackenzie.
Mackenzie, yes.
Mackenzie, aye. Medina.
Yes.
Medina, aye. Mendoza. Mr. Mendoza? I don't see him. He's there. Well,
He is in the panelist list. I will try to unmute his microphone for him.
Go ahead.
Member Mendoza, can you hear us?
I'll circle back in a bit.
Okay.
Molina.
Molina, aye.
Molina, aye. Montel.
Montel, aye.
Montel, aye. Morrow.
Morrow, aye.
Morrow, aye. Alagi.
Olagi, aye.
Alagi, aye. Pacheco.
Pacheco, aye.
Pacheco, aye. Stewart.
Stewart, aye.
Stewart, aye. You.
You, I.
You, aye. Mr. Mendoza, can you hear me? Moderator, do you have some thoughts on this?
He may have lost audio connection. We will have to follow up with him to see what that is.
Let me know when you think you can't do any further follow-up.
Thank you, President Pacheco. This is Karen Fisher. I would suggest that we put a no vote down and move on.
A no vote or an absent, Ms. Fisher? Ms. Fisher?
I'm here.
Okay.
You can't tell, but my brain is working, and I may defer to legal. I may defer to Tara Welch.
Yeah.
If Mr. Mendoza is not responding, do we just put a no vote? Or do we put an absent?
This is Tara Welch, legal counsel. I would place him as an absent vote.
Mendoza absent. The motion is 13-4, 1 absent. The motion passes.
Thank you. We'll now move on to agenda item 17B, adoption of proposed amendments to California Code of Regulations, Title 16, Section 1020.4, relating to diversion evaluation, committee membership rulemaking. I will again ask Wilbert Rombawa, Administrative Services Manager, and Danny Rogers, DCA Regulatory Legal Counsel, to present this agenda item.
Good afternoon, members. The board may, in the 45-day comment period, hold discussion and take action to adopt proposed amendments, if any, to California Code of Regulations, Title 16, Section 1020.4, relating to the Diversion Evaluation Committee membership rulemaking. Action being requested, the board may hold discussion regarding staff recommendations and comments received during the 45-day comment period and may take one of the following actions. A, if the board accepts the recommended response to the comments received.
Wilbert, this is Sarah. I'm going to interrupt. At this point, because the board has already accepted the staff's recommendations and that we're rejecting the comments, the only motion staff is requesting the board from at this point is under A, and that's to approve the recommended response to the comment and direct staff to take all steps necessary to complete the rulemaking process. That entire paragraph is the motion that we're requesting at this point. And that is necessary for us to have a record of the board's vote for the rulemaking. President Pacheco, it looks like Meredith McKenzie has her hand raised.
Ms. McKenzie?
I was just going to move as requested.
And Dr. Yu? Dr. Yu?
Second. I will second. Yeah.
Okay. And Sarah, do we take a board vote on this?
Yes, we are requesting for a board vote. Thank you.
Okay. And Board Secretary, can you please call for the vote?
This is Board Counsel Tara Welch. Can we take public comment first?
Oh, yes. DCA moderator, please facilitate for public comment. Thank you.
This is the moderator. We have opened the Q&A panel. If you'd like to make a public comment, please click on the Q&A icon and type "I would like to make a comment" into the text field, and then you can send that to the host. And this is the moderator. While we're waiting to see if we get any requests for comment, I was able to make contact with Mr. Mendoza, and he's not sure why his phone was acting up, but we're going to try it again with this round of voting. And at this time, I'm not seeing any requests for comment. Would you like me to close the panel?
Yes. And Board Secretary, please call for the vote.
We are now on item 17B, Diversion Evaluation Committee Membership Rulemaking. The motion is in total, on the page 178 after paragraph A, starting with "approve the recommended response" and ending with the words "the proposed text." I will not read it, but we can incorporate that into the written comment. Burton.
Burton, aye.
Burton, aye. Felsenfeld, aye. Lai.
Lai, yes.
Lai, aye. Larine.
Larine, yes.
Larine, yes. McKenzie.
McKenzie, yes.
McKenzie, yes. Medina.
Medina, aye.
Medina, yes. Mendoza.
Can you hear me? This is
I
Board
can,
Member
sir.
Mendoza. Yes.
Go ahead.
Mendoza, yes.
Mendoza, aye. Melina.
Molina, aye.
Melina, aye. Montel.
Montel, aye.
Montel, aye. Morrow.
Morrow, aye.
Morrow, aye. Alagi.
Alagi, aye.
Alagi, aye. Pacheco.
Pacheco, aye.
Pacheco, aye. Stewart.
Stewart, aye.
Stewart, aye. And you.
You, aye.
You, aye. It is unanimous. The motion is adopted.
Thank you, Board Secretary. We will now move on to agenda item 17C, pending regulatory packages. I will ask Wilbur Rambawa to present this agenda item.
Good afternoon, board members. I will be providing a brief update on the pending regulatory packages. The board has currently 11 packages that are in various phases of the regulation process, and I'm going to give a brief synopsis of where each one is at this time. For the basic life support equivalency standards, staff are now working with the Regulatory Council to combine the initial rulemaking documents before submittal to the Department of Consumer Affairs for review, as required prior to submitting the documents to the Office of Administrative Law. At this time, for the basic life support equivalency standards, it was recommended by Regulatory Council that this rulemaking be combined with the continuing education rulemaking for opioids, rulemaking related to basic life support. Board staff are working with Regulatory Council to combine the two rulemakings and develop the formal rulemaking documents to initiate in 20. For the citation and fine regulation, the Office of Administrative Law has approved the citation and fine rulemaking. The regulatory action becomes effective on February 10th, 2021, pursuant to Section 11349.3 of the Government Code. The materials were posted on the board's website on February 16th. This action raises the maximum penalty amount to $5,000 for a Class A and Class B violation of statutes and regulations relating to the practice of dentistry and for the unlicensed practice of an activity requiring licensure by the Dental Board of California. For the dental assisting comprehensive rulemaking, the board approved final proposed language at the February 2020 board meeting, and staff is working with regulatory counsel to update and recreate the 27 forms that must be amended as a result of the changes called for by the proposed language. The proposed language and forms will be presented at a future meeting for approval and initiation for the rulemaking. Determination of radiographs and placement of interim therapeutic restoration. Board staff have drafted the initial rulemaking documents and are working with board legal counsel to review. Once the board legal counsel approves, board staff will submit the initial rulemaking documents to the Department of Consumer Affairs to review as required prior to submitting the documents to the Office of Administrative Law for noticing. Decision Committee membership rulemaking, the board just voted on that in the previous agenda item, and staff will be moving that forward. Elective facial cosmetic surgery permit application requirements and renewal requirements. Consumer Affairs to review. At this point, it was submitted to the director on February 19th, 2021. Law and Ethics Exam Score. This language was presented to the board during the August 14, 2020. These updates clarified that the applicants would need to achieve a criterion reference passing score on the dentistry, law, and ethics combining requirements. Board staff has drafted the initial rulemaking documents and is working with board legal counsel to review. Once the board legal counsel approves, board staff will submit the initial rulemaking documents to DCA to review as required prior to submitting the documents to the Office of Administrative Law. Minimum standards for infection control. Board staff have drafted the initial rulemaking documents and are working with the board legal counsel to review. Once the board legal counsel approves, board staff will submit the initial rulemaking documents to the Department of Consumer Affairs to review as required to submitting the documents to the Office of Administrative Law for noticing. Substantial relationship criteria. The Office of Administrative Law has approved the substantial relationship criteria for rehabilitation, Assembly Bill 2138 rulemaking. The regulatory action becomes effective on January 22nd, 2021. In this action, the Dental Board adopts criteria to be used in determining whether a crime, professional misconduct, or other act is substantially related to the professional practice of its licensees for purposes of license denial, suspension, or revocation. The action adopts criteria for determining whether an applicant for a license or for reinstatement of a license or for the modification of termination of probation of a license has been rehabilitated subsequent to a criminal conviction, professional misconduct, or other act. The act also adopts criteria for determining whether a licensee has been professional misconduct or other act when considering whether to suspend or revoke his or her license. And that is the update for the regulations. No action is being requested at this time.
Thank you, Mr. Rambaugh, for your report. Are there any board member comments? Please use the raise hand feature. Seeing none, are there any public comments? DCA moderator, please facilitate the lines for public comment.
This a panel. If you'd like to make a comment, please click on the Q&A icon on your screen. Type "I would like to make a comment" into the ask field and submit that to the moderator, the host. Seeing no requests for comment, would you like me to close the panel?
Yes, please.
It is closed.
Thank you. I would like to circle back to agenda item number 8, update regarding the California North State University College of Dental Medicine accreditation by Commission on Dental Accreditation, CODA. Due to Dr. Keating's very busy schedule today, he was detained, and we will try to reschedule his presentation at a future meeting. And with that said, we are finished for today. I wanted to thank you for your attention and participation. This concludes the February 26, 2021 Quarterly Dental Board meeting. This meeting is officially adjourned. Thank you.